So I'm delighted to present our next speaker, Professor Sean Kennelly. He's a consultant physician in geriatric medicine at Tala University Hospital. He's clinical associate professor of medical gerontology at Trinity College Dublin. And most importantly, he is chair and lead principal investigator of DRNI. Today, Sean will be speaking about diagnostic and treatment updates.
Thanks so much, Vanessa, and thanks for the invite to speak today. I feel that this is a bit of a handbrake turn on the way the day has kind of unfolded, in that I think what I'm going to talk to speaks to what we're doing in Dementia Trials Ireland and the availability of clinical trials for people who are living with memory disorders. By the same token, I'm going to be talking about research that has been really compiled and put together by hundreds of research centres around the world. I got to give an open declaration, a very key declaration. I'm a clinician who is committed to eventually being able to provide people with the opportunity to prevent dementia one day. I don't know that we'll be able to prevent Alzheimer's disease, but I certainly believe that we will end up in an era whereby we can prevent dementia. I always, whether I'm talking to a room of clinicians or talking to a room of people, from the community or whichever, I always start by going back to these slides, because actually there is nearly always at least one or two people in a room who don't know what is dementia and what are the different types of dementia. Dementia, of course, is not a diagnosis in its own right, and that's important from the point of view of the rest of the presentation. It's an umbrella term. It refers to when somebody, as a result of a memory or thinking difficulty, isn't able to perform their daily activities as well as they were beforehand. So it's not a memory condition, it's a function condition. And oftentimes that's the first place where many practitioners, when they're talking to people, go wrong when they're using the terminology. The most common question I and all practitioners get asked is, what's the difference between Alzheimer's disease? I've had this conversation where I've said, yeah, so we've done these tests and we think this is Alzheimer's disease that's causing your symptom. And the person goes, oh, thank God it's not dementia. And then you have to kind of go, well, this is what that means, or vice versa. So the juxtaposition and the use of those terms is also confusing. So lots and lots of the language you use in this area becomes very, very confusing for people. So we have to have great clarity. And of course, everybody here knows that Alzheimer's disease is the most common cause of dementia. It's caused by particular proteins. So is Parkinson's-related or Lewy body dementia, stroke, vascular disease, frontotemporal dementia, and these other causes. So depending on the proteins in the brain that are mostly causing the symptoms, that's the diagnosis. The symptoms then relate to the part of the brain that's affected. So you can have Lewy body dementia but have symptoms like Alzheimer's disease, because the part of the brain that's affected in Alzheimer's disease is also affected by the alpha-synuclein, that protein in Lewy body. So it's not to be reductive about it, but it's about being able to explain to people why it is they have the symptoms they have is the most important piece of that disclosure. And if the ship starts going in the wrong direction early on, it's so difficult to correct it afterwards. So when people have had the wrong experience at disclosure, where they get misinformation, it can be very, very difficult to help people afterwards. Most of today is going to reflect on Alzheimer's disease, because ultimately over the last 10, 15 years, we've understood so much more about Alzheimer's disease, but it is paving the way for rapid translation to things like Lewy body disorder or frontotemporal dementia and other causes of dementia. So while we've understood an awful lot more about Alzheimer's disease, it's translating quite quickly to the other conditions. And really between 1906, when Alois Alzheimer's described it, in the first, I suppose you could say, evidence of PPI, August Dieter, the lady that he described it in, and who helped us identify the brain pathology that causes this symptom. There was really very little until 1970, when people started accepting that Alzheimer's disease wasn't just a normal part of aging. But it then took another 20 years before we had the first medicines. And then we see this big explosion from the mid-90s, early 2000s onwards, where we're now able to visualize and measure the pathology that causes Alzheimer's disease. In 95 we had the first drug, but between 2001 and 2021 we had no new licensed medicines for Alzheimer's disease. Then we had aducanumab, and I was asked to talk about disease-modifying therapies, so we'll talk a little bit about what we mean by a disease-modifying therapy. But we had aducanumab in 2021, and then we had what I believe is very positive news of lecanemab in the end of 2022. But we're still, disease-modifying therapies and biomarkers are part of a small piece of the additional information. There has been lots and lots of progress over the last 10 or 15 years. So there's lots and lots of reason to be optimistic that progress is being made. I think sometimes the tensions between the language is that you have clinicians and practitioners who are up to date and are trying to translate new information. But you have practitioners then who are working off information that's 20 years old. So people are hearing different stuff on the radio to sometimes what they're getting in the office. And that causes an awful lot of confusion, and it creates a scenario of, is there something I should be doing? If I'm hearing this on the radio, is there something I'm not doing that I should be doing? Is there this new therapy, or is there this new intervention that, you know, I should be accessing and I should be advocating for that people aren't getting? But our understanding of what's causing these pathological processes is much better. Brain health and the potential for dementia prevention with lifestyles. Like 10 years ago, you would have been laughed out of an auditorium if you said that up to half of dementia is potentially preventable by doing lifestyle challenges. That's now very much established fact. There's lots to refine on how we deliver that, but it's pretty much an irrefutable fact that we can intervene in our own risk for developing dementia. Better built environments to support people living independently with Alzheimer's disease. I was touched by the conversation about long-term care and around those community environments and things like that. The actual thing is, it should not be such a source of distress for people if we need to have a more supportive environment. We should always be supporting people to live well within their communities. That should be given. But when somebody may need to translate into an environment that they need additional support, it should not be so distressing. I think so. We need much better attention as to how, you know, those environments look like, and we are getting closer to that. Technology advances and how we incorporate that, understanding the management of response behaviours, medicines not to use mostly, and then the development of medicines that may be useful. So these are all things that are happening, but I'm going to focus in on this very narrow piece of molecules because that's my gig for today's talk. But there's lots and lots going on, and I just want to make sure that everybody understands. I know the importance of all the other stuff that we're making progress on, and ultimately we know with these causes of dementia. For Alzheimer's disease, it's amyloid and tau. For Parkinson's disease, Lewy body, it's alpha-synuclein. For frontotemporal dementia, it's TDP43 or tau. But regardless of the cause of these cognitive symptoms, we know that there's these protein accumulations, toxic protein accumulations, and when we know this stuff, we can go and work on getting drugs to target them. And we know that they build up in the brain over many, many years. So in Alzheimer's disease, we know it builds up in the brain over 20 years. So imagine if we were to say we have a cancer that has a pre-malignant stage for 20 years. We would all say, right, we would be optimistic about coming up with a therapy that can intervene in that. And that's why I think there's many clinicians who are optimistic that as we get better at developing therapies, we will ultimately be able to hopefully develop or deliver a future whereby we will be able to prevent dementia at a certain stage. We talk about biomarkers and what are biomarkers, and it comes down to, you know, that specifics of diagnosis for, let's say, Alzheimer's disease, which is amyloid and tau. We know that amyloid is outside of the brain cells, and it causes those brain cells to shrink, whereas tau is a protein that's within the brain cells and causes them to break down. And we know that in particular as tau builds up in the brain. So amyloid generally builds up first, and then the tau becomes toxic, and it causes the brain to shrink. And if we look at what correlates mostly with the symptoms, it's the accumulation of tau. So amyloid starts the process. Tau is, if you like, the spanner in the works that causes it to spin out of control. But there's also things like our inflammatory system within our brains gets kicked into a high gear, and that causes an awful lot of damage as well. And ultimately, that's what leads to the symptoms of cognitive decline, which happen generally about 15 to 20 years after we get these protein changes in our brain. A biomarker is a molecule or a characteristic which gives, you know, clarity to the pathological process. I always say our most important biomarker ever and always will be how we take a history and story from the individual and from the carer. It's got to be the first. No other biomarker has relevance in the absence of the story, and all are going to be prone to giving us misinformation. But we've developed other biomarkers through looking at MR scans and CT scans and looking at functional PET imaging. And as of just December of 2022, we're now able to do our first amyloid PET scans, which is a special imaging scan clinically in Ireland, and that's done in the Blackrock Clinic. And that's, you know, where people don't have to necessarily have the lumbar puncture that we would do. You know, in our memory service, we do between 150, 200 lumbar punctures a year to give people more accurate diagnosis and people with mild memory symptoms to help them understand, you know, what might be causing those memory symptoms. But very quickly, blood biomarkers are coming through, and I always say this is the big disruptor, not actual disease-modifying therapies. we're getting to a stage whereby for a very inexpensive blood test and a memory screener, a GP will be referring on to memory services and saying this is likely something that you need investigated. And that may be positive at the age, certainly from mid-50s onwards. So there's a whole cohort of people who don't know that they may need access to services. So at the moment, we know that there's a huge demand for our services, but there's actually an even bigger demand probably coming down the line as to how we're going to deliver some of these therapies. So when we talk about emerging therapies, it's often good to talk first about our current therapies. Like I said, memantine was the last medicine licensed for Alzheimer's disease, and that was in 2002. So we've had no new medicines for such a significant condition for almost 20 years. Donepezil and rivastigmine are still the main medicines used, and they work on that hypothesis that if we increase a chemical called acetylcholine within the brain cells that are working will be in a better position to continue working, but they don't alter the course of the illness and that they don't prevent the breakdown of those brain cells or the loss of those brain cells. And that's what disease modifying is. A disease modifying therapy is a therapy that when you deliver it will stop those brain cells being damaged. So it's not just about making the ones that are there work better, it's about preventing the loss of further brain cells. And when we look at drug development pipeline, if we were, oftentimes it's portrayed as negative, but there's about 142 agents in 172 trials. This is this year's data, looking at new therapies for Alzheimer's disease. There's 31 of those treatments in phase 3 trials, which is advanced studies. The majority of those are targeting the underlying biology, so their primary goal is towards disease modification. 10% are cognitive enhancing, 7% are there to hopefully help with some behavioural symptoms. So there is a huge amount of work going on in this area. And we're beginning to see some of that trickle through into potentially therapies that we will be able to deliver in a clinical setting. Before I go into talking a little bit more about it, I think the key thing is what we've understood is amyloid as that protein is not a singular entity. As we would now understand by many cancers, there isn't a singular entity. There isn't a single type of breast cancer, for example. There isn't a single type of Alzheimer's disease or amyloid as it exists either. This protein kind of exists in different forms. Some of it is in small form, some of it in soluble form, and some of it is in condensed or plaque form. And what we know is there's a particular toxic form called oligomers that actually are probably responsible for most of the disease process. So actually, medicines that target it versus other forms of amyloid are probably more likely to be successful. And why is that important? Because we've had mixed results with different therapies. And it's easy to kind of question and say, well, maybe we're wrong on the target. But actually, the target exists in multiple different formats. So actually, it's about having and developing medicines that target the actual toxic form of that protein as opposed to a generic if we just remove it from the brain. If the amyloid we're removing from the brain isn't the amyloid that causes the memory symptoms, it's not going to help. So it's about targeting the right forms of amyloid. And that's the difference between, let's say, aducanumab, which looks at plaque, which is that organized amyloid, versus, let's say, a lecanemab, which looks at these protofibrils. So that's why we see different results sometimes with some of these different trials. Lecanemab is that medicine that was announced at CTAD. That's the clinical trials and Alzheimer's disease meeting in December. And essentially, over 18 months, when people were given 2 weekly infusions, so this is not a benign intervention or benign therapy, it did suggest a slowdown, a reduction in the rates of decline. Now, it's important to kind of also tease out what does that mean, because there was debate about what is a relevant rate of decline or what is an appropriate rate of decline that you'd expect. These were people with MCI, mild memory symptoms. Over an 18-month period, most people with mild cognitive impairment or MCI that attend my clinic don't decline. So you're looking at very marginal changes that you would expect to see anyway. So if you see any change in a group of people with mild cognitive impairment that's different, it's probably suggestive of downstream where you get to see those bigger changes are probably going to be amplified. but we do need to follow forward. Over 18 months, it's very, very difficult to be making those judgments. It's mostly over 5 to 7 years that you're probably going to be able to understand this. What I thought was reassuring about this study is that at all the levels, and there was about 7 or 8 different levels from the point of view of memory scores to daily activity to behavioural scores to lots of, on every single metric in this blinded trial, therapy benefited versus no therapy. So it was a very consistent message. So as opposed to other studies where you get one thing was better, another thing isn't, it was a very consistent message that came through. So that's why clinicians kind of were interested in it, and that's why we're probably more optimistic about this than we are, let's say, about aducanumab, which was the other medicine. Aducanumab is licensed in the United States, and there are people, from lots of other jurisdictions who go to the US to try and avail of aducanumab therapy. Depending on who you ask, it was the first disease-modifying drug for Alzheimer's disease or the worst drug approval in the history of the FDA. And to be honest, the answer is probably somewhere in between. And this is the difficulty, is you get into this polarized debate that doesn't help anybody, where you got one camp versus another camp. And the reality is we will never understand how any of these medicines are going to happen or are going to be useful within the construct of clinical trial. And I say that as a clinician who does clinical trials. We will only get the first piece of information from a clinical trial. The application in the real world is what always tells us about the usefulness and risks of these medicines, because we don't live in a clinical trial environment, and we don't deliver our medicines day to day in a clinical trial setting. So I think what the threshold we're looking at is when we have enough information to be reassured that it's safe enough to try and deliver the first potential therapy to individuals to really impact on the disease progression. And for people who sit on the other side of my desk, and for me who sits on my side of the desk, I absolutely have a full appreciation of what's involved in all of those decisions as we're trying to weigh up where that risk-benefit ratio lies. And the absence of another therapy, is part of that. Donanemab is another medicine that's hopefully results will be released this year. So hopefully there will be more positive news that will come out probably in the middle or later end of this year about another medicine that's been developed by Eli Lilly. The safety of these medicines, well, the main issue that people may have heard a little bit about is this thing called ARIA, or amyloid-related imaging artifacts. So some of these medicines, when they're shifting amyloid from the brain, in particular from the blood vessels can get a little bit leaky. And we can get little bleeds, and we can get little swellings in the brain. They're mostly asymptomatic. They mostly don't cause symptoms, but we don't know about them. And we're kind of trying to figure out these artifacts or these things that we see in these scans that really before these medicines we weren't seeing. So it's the main side effect that we look for. It's the main reason why we're going to need to be doing lots of MRI scans when we're giving these medicines. And that's really my next. How we deliver these medicines or potentially deliver these medicines requires a whole systems change. We have to get back towards or to a model of expertise, whereby it will reflect far more, if you like, our oncology model and the delivery of these medicines for the people who will be eligible. So it'll be where, I often say that the future is probably, over the next 5 years. So this isn't, a far off vista. Somebody will go to their GP, have little or no memory symptoms, have an MMSE or some memory screener, have a blood-based biomarker. Their MRI scan will be booked, and they'll be referred to a memory service. Within a month, they'll attend that memory service and have their MRI scan, and they'll have a detailed clinical neuropsych workup and everything like that. They'll have either the amyloid PET scan or they'll have their CSF biomarker, which will establish that they have Alzheimer's disease pathology. We know that a third of people who went into some of the earlier anti-amyloid trials never had amyloid because they didn't have biomarkers. If you just apply clinical phenotype, if you just apply, I'm the doctor, I know what I'm talking about, actually, only 2/3 of the time are we right. So those biomarkers are very important. Then people will receive their treatment, and hopefully by receiving that treatment and monitoring it, there is that potential for us to watch the clearance of this protein, watch for it to reaccumulate. If it reaccumulates, treat it again, remove it again. And there is the potential for somebody to live well with this condition. So it's similar to if we were to imagine something like HIV. We never cured AIDS, but we can manage HIV. If we can manage Alzheimer's disease, we may prevent dementia. Okay, so it's not about necessarily curing Alzheimer's disease. I never cure high blood pressure. I only treat high blood pressure. I never cure diabetes. only treat diabetes. And similarly, we may get to a similar piece for Alzheimer's disease and the other conditions that cause dementia. So I do think a new era in Alzheimer's disease and other therapies I think it prevents really exciting opportunities, but there is a whole raft of things. I think it's going to be probably 2 to 3 years before we'll be delivering these in clinical practice with the best intentions. I think there's also, we have to look at, what is a meaningful effect size and make sure that we're making, prudent use of resources and how we go about this. I think we need to always reflect, when we're treating somebody with Alzheimer's disease, they usually have not just got amyloid, tau, they have vascular disease, they've alpha-synuclein pathology, TDP-43 pathology, all of those other pathologies are in their brain. So that's why we don't see huge dramatic, we're never going to be seeing an absolute eradication probably of cognitive symptoms until we get therapies that also address those other pathologies. So it's not just about an amyloid hypothesis. There's lots of other reasons why people develop memory difficulties. We need to get on to developing treatments for these and some of these medicines that I showed earlier on are actually focusing on things like Lewy body. What happens to people and how we support people live well with dementia is still absolutely essential. There should be no tension in a model. There's only need for one model of care. There's no need for a separate model for people who come through this pathway versus another pathway. It's absolutely essential the model of care is accessible for everybody, whether or not you're getting these therapies. Blood-based biomarkers is actually going to be the real disruptor as much as disease-modifying therapies. When you're telling people with little or no symptoms that they have amyloid in their brain at the age of 50 or 55, and we're very, very close to that being a reality, whether it's a positive or whether it's a negative, that is going to be a real disruptor in the demand for services. And the application of disease-modifying therapies, and Mary mentioned it, to other conditions and high-risk populations that we know. So people, familial Alzheimer's disease and those younger onset groups and people with Down syndrome who've been excluded in most of these disease-modifying trials, despite us knowing that they have an almost inevitability of developing Alzheimer's disease. Those are the real key issues. So there's lots and lots. Despite the progress just creates more issues and more, but I think we're in a scenario whereby some of these opportunities are things we only thought we could dream of. And I always, yet again, it's really important. We already have a disease-modifying therapy. Brain health is our disease-modifying therapy. And for all of us, as much as possible, it's about doing those things, and we know that we can modify our own risk. And I kind of always try and finish with this slide to sort of say addressing these things influences our own risk. And no matter what molecules we're given to people, this is going to be the adjunct therapy. We have to keep a focus on this stuff. So that was a bit of a whistle-stop tour through what's going on at the moment. So thank you very much.